I think Lavanya, we can start.
No. Good morning, everyone. Today's topic will be hepatorenal syndrome. Myself, Dr. Lavanya. So, why are we so bothered about hepatorenal syndrome? Why are we talking about acute kidney injury with respect to liver patients? Is it different from the routine acute kidney injury? It is a very life-threatening situation if left untreated, and it is one of the biggest challenge for a critical care physician. Does it differ from the routine acute kidney injury? Yes, in a lot of ways. So it is a serious form of renal dysfunction in patients who are having advanced liver disease with cirrhosis and ascites, and which carries a significant morbidity and mortality, and it is a part of acute and chronic liver failure syndrome. So it differs as per pathophysiology. It is not a single factor that is playing a role here. It is multifactorial, and it is multiple mechanisms have been proposed in the development of HRS. So it is more complicated to understand. And routine biomarkers that usually we use for diagnosis of acute kidney injury has significant limitations in cirrhosis patients. And the main thing that has to be done is the early diagnosis here. Early diagnosis and differentiate from other causes, and a systematic approach has to be followed compared to any other acute kidney injury. So, sorry for the this thing, sir, because I could not place a full slideshow. It is coming like this. So initially, over the years, in the last few decades, the definition and criteria that has been put up for hepatorenal syndrome has been changing. Usually, International Ascites Club of Ascites, ICA or IAC, definition is being widely followed. In 1996, they called the acute kidney injury in the background of cirrhosis as a hepatorenal syndrome. And they gave a criteria with major and minor criteria to define hepatorenal syndrome. The major criteria included the patient having chronic or acute liver disease with advanced liver failure and portal hypertension with a creatinine of more than 1.5 and creatinine clearance of less than 40 ml per minute. And the most important point is the patient should not be having shock. That is, there is no shock, absence of shock, and no infection, and no nephrotoxic drugs, and absence of GI losses or renal losses has been ruled out. And when we give a plasma, expand the plasma volume or give a fluid resuscitation of the single number, that is 1.5 liters isotonic saline, and after the diuretic withdrawal, there should be, when there is no sustained improvement, that is decrease in creatinine to less than 1.5. So this is one of the criteria, major criteria to define HRS. And proteinuria of less than 500 mg per dl, and no ultrasonographic evidence of renal parenchymal changes. And the minor criteria included urine volume of less than 500 ml per day, urine sodium of less than 10, urine osmolarity of more than plasma osmolarity, and urine RBC of less than 50 per HPF. So looking at all these points, we understand that it is not HRS has a typical criteria to say that it is HRS, but it is mostly a diagnosis of exclusion. So we exclude the shock, we exclude infection and nephrotoxic drugs and other causes, and volume expansion is done. Then if still there is no improvement, then we call it as a HRS. So it is mostly a diagnosis of exclusion. So over years, as AKI definition is changing and more pathophysiology of HRS we have understood, they have changed the 2000 criteria. Not a major change, but minor. But they have added the volume expansion with albumin. It has to be done with albumin, not the isotonic saline. The albumin dose that was recommended was 1 gram per kg body weight, up to a maximum of 100 grams per day. Apart from this, they have removed the minor criteria. So no major changes in other part of the definition. So we should keep in mind that it is a diagnosis of exclusion. This ICA criteria, which has been given in 1996, followed by 2007, has many limitations. So the main limitations being, so they've given a single absolute value, value that is 1.5, more than 1.5 of serum creatinine. So we all know that it should be a dynamic change. It should not be, it's a relative change compared to the baseline value, not a single value. And also in creatinine, the creatinine in cirrhosis is usually underestimated. The kidney function is underestimated because of multiple factors. They have sarcopenia, which leads to underestimation of creatinine. Also, there is increased tubular secretion of creatinine. And the bilirubin itself can interfere with the calorimetric assay of creatinine. Because of all these, probably when we reach an absolute value that is given in the definition, that is 1.5, we may be dealing with the advanced form of renal failure, and we may delay the treatment if you keep this definition or criteria in the mind. And the second limitation being obligatory elimination of volume depletion. So the definition is saying to give 1.5 liters of the isotonic saline initially and then the albumin. So is it tailored to the patient's volume status? No. And there is none of the hemodynamic parameter being monitored, which we are using dynamic parameter. None of the parameters have been used to assess the volume status and see the responsiveness. So patient may be either volume depleted or volume overload, we will never know. So the another point that mentioned is there should not be any recent or current exposure of nephrotoxins. When they said that they decompensated cirrhosis patients or liver disease patients, they have multiple hospitalizations and spontaneous bacterial peritonitis, for which in the previous admission or current admission they receive antibiotic therapy, which some of the antibiotics can be nephrotoxic. So having to rule out completely the nephrotoxin exposure to get HRS diagnosis. So it is not right, because many of the drugs can cause acute tubular necrosis also. And absence of abnormal renal imaging, it mentions. But to get a renal imaging and to see renal parenchymal changes in case of massive ascites that these people have, it is most of the times difficult to rule out, to check the corticomedullary differentiation and parenchymal changes. It might become very difficult. And urinary sodium of less than 20 and fractional excretion of sodium less than 1% is almost there in every patient, and it did not accurately establish the diagnosis of HRS when a study was conducted. So with all the limitations, we understand that we definitely need some better criteria or the definition. And also the AKI definition has been changing in the last 2 decades, from Rifle criteria to the Nekin criteria, and KD got the recent most in 2012. So with that criteria, and also having understood the better pathophysiology of HRS, so in 2015, ICA, International Club of Ascites, has changed the definition to the current consensus of definition being an absolute increase in, this is the basic AKI in cirrhosis. This is the definition of AKI in cirrhosis, which is mostly a non-HRS AKI. So it is absolute increase of creatinine at least 0.3 within 48 hours, or 1.5 times the baseline within past 1 week, last 7 days. The stage 1, 2, 3, mostly like the KDIGO guidelines, which says 1.5 times of the baseline in stage 1, 2 to 3 times of baseline in stage 2, greater than 3 times baseline in stage 3, and creatinine of absolute value of more than 4 with increase in 0.5 of creatinine, or patients are on renal replacement therapy. So traditionally, we all have been taught that HRS is of 2 types, type 1 and type 2. Type 1 is a rapidly deteriorating kidney. Type 2 is a slowly steady progression with a better prognosis. So initially, HRS type 1, the criteria has been that the deterioration in kidney function with the creatinine increasing by more than 100% from baseline to above 2.5 within a 2-week period. The prognosis is very poor. The survival rate is very low, and less than 2 weeks of survival has been observed. And HRS type 2, it is more gradual and slowly deteriorating kidney function to a moderate level only, not a very severe degree of renal failure. Creatinine is around 1.5 equals to or more than 1.5, and the survival is better in these patients up to 6 months. So this is the oldest classification of HRS that has been put up. After the 2015 diagnostic criteria that has been put up for HRS-AK by ICA, which includes almost the same points which we have seen initially, where patient has cirrhosis and creatinine of more than 0.3 in last increase in more than 0.3 in last 48 hours, and more than 50% from the baseline, and no response to the diuretic withdrawal and volume expansion with albumin, absence of shock, and to rule out the parenchymal disease by proteinuria, microhematuria, and ultrasonography, and to rule out renal suggestion of renal vasoconstriction with a fractional expression of sodium less than 0.2%. So this is the new diagnostic criteria that has been given in 2015 by ICA. So this is how the evolution of diagnostic criteria for HRS has happened. So initially 96, 2007, and 2015, there's no minor criteria, and there is the new definition says that stage more 2 or more than 2 AKI is said as HRS, and also they've removed the terminology HRS type 1, and probably they've used HRS AKA instead of that. So the current nomenclature or classification, the old one being HRS type 1 and type 2, right now it is HRS AKI. We have already seen the criteria for HRS AKI, and HRS non-AKI. It's some only in some classifications, some studies, some papers they've mentioned this criteria. Most of the places they mentioned directly CKD. In HRS AKD, acute kidney disease, the creatinine increase is less than 50% in 3 months, whereas HRS AKI more than 50% in 3 months. And based on GFR less than 60, and no other cause of kidney disease is there, cirrhosis with ascites is present. HRS with HRS CKD, where there is no other cause of kidney disease, GFR is less than 60. So this has been a current nomenclature since 2015. So what is the pathophysiology of HRS? As I said, it is a very complicated mechanism. Multiple theories, mechanisms have been put forward, out of which most commonly understood or described mechanisms have been 2 theories mainly, that is vasodilatation theory and inflammatory theory. On left hand side in this figure A, that shows that early cirrhosis and portal hypertension in a patient, and this is advanced cirrhosis and portal hypertension, how it differs. So we all know that patients with portal hypertension, they have excessive production of vasodilatory substances, that is nitric oxide, carbon monoxide, and other endocannabinoids, which lead to excessive vasodilatation. That leads to a splanchnic vasodilatation as well as a systemic vasodilatation. Because of the systemic vasodilatation, there is a effective hypovolemia. So also along with this, another theory that is inflammatory theory, where because of increased intestinal permeability, which is usually present in portal hypertension patients, there is increased bacterial translocation. More bacterial products come from the intestine to the circulation, and there is bacterial translocation that occurs. And that includes PAMs also, pathogen-associated molecular patterns, which again have vasodilatory effects. So again, ultimately there is a vasodilatory state. So with this vasodilatory state and effective hypovolemia, usually body obviously tries to compensate. So the cirrhosis is not very advanced and other factors are not there. Hence, there is activation of vasoconstriction systems in the body to increase the cardiac output. The vasoconstriction systems being renin, angiotensin, aldosterone system, sympathetic nervous system, and arginine vas. So usually they usually be able to at least increase the cardiac output, and hence there is a high cardiac output and ascites. And the other theory that said bacterial translocation along with increased PAMs being causing vasodilatory state. Also, there increases pro-inflammatory cytokines, which further leads to arterial vasoconstriction and their microthrombi formation in the kidney, and there can be direct tubular damage by the DAMs, that is damage associated molecular patterns. It may not be always inflammation with infection. Non-infectious causes like drug-induced liver injury and also alcoholic hepatitis. These can lead to formation of dams, and which in itself can cause a direct tubular damage and microthrombi formation, platelet leukocyte activation. In turn, it causes the damage to the kidney and renal dysfunction occurs. But when there is compensated cirrhosis, there will be normal GFR, and I already told that it's able to increase the cardiac output, so there is high cardiac output. But in advanced cirrhosis, with the same mechanism, there are other factors. Usually, any HRS, occurrence of HRS has a precipitating factor in the background. So most of these patients have upper GI bleed and still hypovolemic because of loose stools that was caused by the excessive lactulose dose, diuretics, and their most important precipitating factor is infection, and this can have cirrhotic cardiomyopathy. And some patients were kept on for variceal bleeding, non-selective beta blockers. All these they interfere with the mechanisms, the compensatory mechanism. There is no sufficient increase in cardiac output is one thing, and the pro-inflammatory cytokines will increase in much increased proportion, which leads to the higher kidney damage, leading to renal dysfunction and decreased GFR. So always what it tells is the precipitating factors will decrease the compensation, and also the deleterious effects are more. So always find the precipitating factors and treat it first. So the important points that to be noted in pathophysiological effects of pathophysiology of HRS is, so one is mainly splanchnic vasodilatation, which leads to decreased systemic vascular resistance, and there is a effective hypovolemia and the decreased mean arterial pressure. So this leads to increased renal vasoconstriction because of the activation of vasoconstrictor systems. Kidney is very sensitive to vasoconstriction systems, and so that is why increased responsiveness to vasoconstrictors occur, and there is a decreased renal blood flow and decreased GFR. Along with that, we already mentioned that there is a possibility of cirrhotic cardiomyopathy, that is hepatocardiorenal syndrome. So hence it is just simply not a liver and kidney. It is usually when the HRS is occurring in liver patients, it's a part of multi-organ failure. So all other organs are involved. The heart, liver, kidney, gut, everything is involved. So altogether, the final outcome is increased vasoconstriction, decreased renal blood flow, and decreased GFR or tubular hypoxia leading to acute kidney injury. So there is renal hypoperfusion, there is direct tubular damage, there is microthrombi or microvascular dysfunction, and there is inflammatory signals. So all this will lead to acute kidney injury in liver patients. So having seen the pathophysiology, so how to diagnose and how to manage the patients of HRS. So like traditionally the biomarkers that have been under studies for the routine AKI, like cystatin C and creatinine in combination showed a better assessment of GFR, sorry. NGAL, interleukin 18, and KIM1. So all these biomarkers are being studied in case of liver patients also, HRS patients also. But I think there is still the limitation for clinical use because of its availability, and the cutoff values are not very clear. So yes or no. So whether to use biomarkers, I think more studies have to come up to apply to the HRS also. So initially, treatment of HRS, the main thing is to recognize HRS first of all. So going through all the criteria and the pathophysiology, we understand that how to rule out other causes, how to treat some of the causes, and then come to a conclusion that it is a HRS. So recognition is very important. Even to treat it before treatment, recognition is very important. So there should be a frequent monitoring of creatinine levels when a patient suspected HRS or any AK in the background of cirrhosis is coming to us. And when the decompensation or the patient is coming with symptoms, other symptoms like fever, the infection, so always send a blood culture from the possible sources of infection, and empirical broad spectrum antibiotics have to be given. And any hypovolemia that is due to excessive diuresis has to be corrected. Any loose stools, diarrhea has to be treated, and adjust the dose of lactulose. And also send and PRBC transfusion, because these patients, most of these patients can present with upper GI bleed, and most of the patients are kept on non-selective beta blockers, which have to be discontinued. And always send a routine urine examination to see if there is any hematuria or proteinuria or various scars that can rule out a structural cause of AKI. So after all these general measures and maintaining the effective circulatory volume, this is the key management strategy, but which I already told, dynamic parameters are preferred, but it is difficult to assess in cirrhotic patients. So after all these general measures, some of the patients may still improve without any definitive management. So we need to see for the HRS reversal in the form of decrease in creatinine. And if HRS diagnosis has been established, other precipitating factors have been corrected and treated. Now the next point is how to treat HRS. Are there any is there any evidence of the diagnostic role of albumin and other vasopressors? So albumin is a plasma protein, 60% of the plasma protein in healthy individuals. Usually in cirrhosis patients, this albumin is decreased, both due to decreased synthesis and there is increased catabolism also. And also the albumin is structurally modified and functionally impaired, that it cannot work at its full capacity. So not only for the volume expanding effect, the other effects that have been proposed for albumin are antioxidant, anti-inflammatory effect, immune modulating effect, endothelial stabilizing properties. And also it was said that there is beneficial effect on cardiac output by increasing the cardiac contractility. But do they have clinical impact, all these parameters? We don't know. Because antioxidant property of albumin there is an increased oxidative stress in cirrhotic patients. The albumin usually is in reduced state. So to decrease the free radicals and to further have antioxidant effect, it theoretically may not, theoretically it may be okay, but clinically it may not imply and cause antioxidant effect exactly. So the ICA has recommended the dose of albumin as 1 gram per kg body weight with up to 100 grams per day. This is initially to differentiate pre-renal cause of AKI from HRS AKI. So if there is an improvement, we say that it is HRS AKI. And thereafter, the dose recommended is 20 to 40 grams per day. So always albumin and vasopressors go hand in hand. Never one albumin is given or vasopressor separately. They both in combination, when used in combination, they improve the hemodynamic abnormalities. The rationale behind using vasopressors here, both splanchnic and systemic vasoconstrictors. Splanchnic vasoconstrictors, we have seen the pathophysiology very clearly, where it says that there is a splanchnic vasodilatation. Hence, all the effects of vasoconstrictor mechanisms come into picture. So when we reduce the portal inflow using splanchnic vasoconstrictors like terlipressin and octreotide, some of the intravascular volume is intravascular volume to the systemic circulation. So there is a increased filling in the central compartment. and also reduces the portal pressure. So basically, it will reduce the portal inflow. And also it will improve the renal circulation by decreasing the compensatory activation of various, same way, when we are decreasing the splanchnic vasodilation, the compensatory mechanisms that are vasoconstrictor mechanism do come down. So the systemic vasoconstrictors like midodrine and norepinephrine, they act by increasing the MAP, mean arterial pressure, hence the renal perfusion pressure. So most commonly and widely studied and being used worldwide is terlipressin, and it is a vasopressin analog. It acts by V1 receptors of the vascular smooth muscle cells, and it induces vasoconstriction. So, like I said, because of the systemic, because of the splanchnic vasoconstriction, it will lead to the resolution of HRS or HRS reversal. So there is decreased portal pressure, which this is already discussed, decreased portal pressure, and also there is intrahepatic resistance is decreased, and there is redistribution of the blood volume. So that will increase the MAP, and also there is improvement in renal circulation. Also, terlipressin was said to reduce bacterial translocation in decompensated cirrhosis. Hence, the extent of vasodilatation in the presence of infection has come down. As per some studies, it was true. So this was a study which was done recently in 2021. It is published in NEGM, and it is called CONFIRM trial. So CONFIRM trial has compared over 300 patients, the largest study done in recent times, where they've compared terlipressin plus albumin to the placebo, is the control group or placebo group. So it did show that terlipressin is effective than placebo in improving the renal function and also survival at 90 days. But at the same time, it has showed some serious adverse events like respiratory failure. Along with that, other adverse effects like abdominal pain, nausea, diarrhea. But for this respiratory failure, so this was not, it is associated with a serious adverse event like a respiratory failure. It was not further used, probably not used in North America and not still available. So that is what is mentioned in most of the articles, but query FDA approval recently is what I have read. So that has to be yet studied and used in US. But otherwise, terlipressin is being used worldwide. The dose being 0.5 to 2 mg IV every 4 to 6 hours. So stepwise dose increments should be done every few days if there is no improvement. And up to maximum of 12 mg per day can be used. This is the proposed maximum dose, as there are no side effects. But it is contraindicated in cases of CVA, peripheral vascular disease, coronary artery disease. The maximum treatment is up to 14 days. So other vasoconstrictor agents that have been used is only terlipressin has shown some improvement in HRS, some improvement in HRS reversal, and survival at 90 days. But the overall survival, transplant-free survival, has not been shown any, has not increased with the terlipressin as per most of the studies. Some studies have used terlipressin infusion also, 2 to 4 mg per day as an infusion, which said that there is less side effects, but not proven clinically. And other vasoconstrictor agents, vasopressin has been used but not recommended to use. Noradrenaline, which is alpha-1 agonist, which has been widely used again. And there was a study which compared noradrenaline to the midodrine and octreotide combination, which said noradrenaline is a better combination. And there was a study where noradrenaline was told that it is almost equally efficacious to terlipressin, but not showing any mortality benefit as terlipressin. So noradrenaline is used as a continuous infusion with 0.5 to 3 mg per hour because it needs a line wide bore, or it needs a center line and ICU admission. So the initial inclination towards terlipressin, which can be given even in the non-ICU setups. So the target with the vasopressors to titrate to achieve a 10 millimeters of mercury increase in the MAP. Other combination. So octreotide itself, if it is used alone, there it is ineffective. When it is used along with midodrine, which is again alpha agonist, used in doses of 7.5 to 12.5 orally 3 times, and to achieve a 15 millimeters of mercury in the increase in the MAP. If octreotide in the doses of 100 to 200 micrograms subcutaneously 3 times daily, or 25 mics bolus followed by IV infusion of 25 micrograms per hour. If these are used in combination along with albumin, it has shown beneficial effects. And there was another combination that was used, dopamine and plus furosemide, not many studies, and did not show any clinical benefit. So these are the vasoconstrictors that have been used in the treatment of HRS. And after albumin and vasoconstrictors, if there is no HRS reversal or decrease in the clinical status or renal function. So extracorporeal therapies. So the renal replacement therapy. So the preferable mode of renal replacement therapy is continuous renal replacement therapy, because most of these patients have hemodynamic instability, and two, the solute shifts and fluid shifts are should be slower, and they have most of the patients have cerebral edema. So in such setups, it's always better to use a CRRT mode of RRT. And other extracorporeal therapies like plasmapheresis and MARS, molecular adsorbent recirculating system, like it has shown beneficial effects in other decompensated forms of cirrhosis, like to treat hepatic encephalopathy. But in HRS, none of these therapies have shown any beneficial effect. So how long to do the renal replacement therapy before the transplant? So the increased duration of pre-transplant RRT has shown bad prognosis post-transplant. So it is most of the times more bridge to the renal liver transplant. So whether to initiate or not should be based on the clinical status, but the mortality benefit is not seen by using RRT just as a non-bridge. It is mostly towards the liver transplant. We are bridging the patient with the RRT. The surgical options, tips can be done as it is not shown very efficacious, but in type 2 HRS, initially it was proposed that with refractory ascites who are requiring large volume paracentesis repeatedly, that can be considered as a treatment option. Liver transplantation should be the ultimate thing. If there is a repeated decompensated episodes with HRS, it should be done for candidates with type 1 HRS less than, that is HRS AKI, for less than 4 weeks. And what is the indication for simultaneous liver and kidney transplantation? There are specific indications where it can be done. The organ procurement and transplant network has given us criteria for the simultaneous liver and kidney. So which included along with the sustained AKI more than 6 weeks, and GFR of less than 60 with inherited metabolic disorders. And they have also given a safety net option. So a patient who is registered on kidney waitlist between 60 to 365 days after transplantation and is either on dialysis, has an eGFR of less than 20, so will qualify. So that to prevent the kidney transplant candidates deprived of the organ. There's one emerging therapy that was mentioned in some of the papers, serelaxin, which is a recombinant human relaxin too. It increases the renal blood flow by reducing the renal vascular resistance, and also reverses endothelial dysfunction, but still in the study period. So to summarize the acute kidney injury, the definition wise, creatinine increase of more than or equal to 0.3 within 48 hours or more than 50% from the baseline. So we need to determine the phenotype first, whether it is structural or any pre-renal azotemia is present. So if there is a structural disease, treat according to the etiology. If there is a pre-renal, determine the stage 1, 2, 3. So after determining the stage, main important thing is to assess and treat for the precipitating factors. You withdraw the diuretics, volume expansion should be done with the albumin, and then monitor if there is no improvement. If there is no improvement, again, criteria for HRS, if they're fulfilling, treat with vasoconstrictor and albumin. If there is response, yes, then you can go back to monitoring. If there is no response, he's a transplant candidate. So similar thing. So there was a spectrum that has been proposed in some papers where not HRS1 clearly do not initiate any vasoconstrictor therapy. Possible HRS, in possible HRS or in a probable HRS, sorry, probable HRS do initiate vasoconstrictor therapy and IV albumin. And in some places, because probably this is in the US where terlipressin is not very much available, they usually use midodrine and octreotide combination if there is no response, initial response to the vasoconstrictor therapy and IV. So to summarize, renal dysfunction is a common finding in most of the advanced liver disease patients, and it carries a very significant morbidity and mortality. And we have seen that pathophysiology is multifactorial. Different theories have been proposed, and the biomarkers might need some more research to be helpful in the clinical settings. And renal resistivity index can also identify in AKI. This has to be further studied. And identification early is the key here to improve the outcomes. And mainstay treatment is albumin and vasoconstrictors, mainly terlipressin, and should consider for liver transplantation as early as possible because this carries a very poor prognosis if left untreated. Thank you. Thank you.
Srinivas, we are not able to hear you.
The voice is breaking, sir. Can't hear you.
Srinivas, there seems to be some issue with your internet. Hello? Hello?
Hello?
Better now.
Can you hear me now?
Yes, sir.
Yes.
Yes, sir.
Yeah, so I'll keep my video off so that this, the bandwidth is better. So it was the understanding of HRS has improved after we have reclassified it as HRS AKI and HRS CKD, but still there are gray zones in the understanding and the management of this complex syndrome. Most importantly, we should always remember that these patients with portal hypertension and ascites also have an abdominal compartment syndrome. So, what is the intra-abdominal pressure and what is the contribution of this intra-abdominal pressure to the pathogenesis of the renal dysfunction is something we need to factor in before we put the patient in as HRS-AKI or HRS-CKD. The role of midodrine has increased over the last 5-6 years, and its availability has also got better in this country. What is the exact situation where you use it? What happens to those patients who are hemodynamically unstable, and what is the target for restoring the perfusion is something we don't know as far as the targets for hemodynamic optimization are concerned. Nevertheless, it's And the role of plasma exchange. Plasma exchange does not always have a therapeutic role in these patients. For those patients who are waiting for a transplant, if the coagulopathy and liver functions are deranged and you want to buy time as a bridge, just like you use VA ECMO or VAD as a bridge for transplant, you can use therapeutic plasma exchange as a bridge to liver transplant as well. So that's a few points I wanted to add. Ghanshyam, you want to say something?
Uh, I'm sure Srinivas would remember, when during our fellowship days, HRS was universally considered to be fatal. In fact, many a times when we used to get patients with background cirrhosis with acute kidney injury, many a times we wouldn't even take them into the ICU. I think that mindset has changed over the last many years. Better understanding and better therapeutic solutions. We see a good number of patients with HRS who kind of get back and get their transplant done. Again, if you just look at the whole concept, irrespective of what kind of definitions we use, the whole emphasis again is on stressing the basics, optimizing volume, avoiding nephrotoxic drugs, uh, you know, uh, controlling of infection. That seems to be the fundamental idea for almost every patient in the intensive care unit. It just comes back in one way or the other, no matter which clinical condition we deal with. So, thank you, Lavanya. I think it was a very, nicely explained topic on hepatorenal syndrome.
Thank you, sir.
Thank you.
Thanks for
Thank
giving
you.
the opportunity, sir. Thank you.
Thank you for joining us, and thank you, Lavanya, for this presentation. Next week, we will look at a similar syndrome, the cardiorenal syndrome, where similar complexities and more varied presentations can happen. And we'll try to go through the same systematic way on how to approach a patient with cardiorenal syndrome. So those of you who have any queries or comments on this complex scenario can post their queries on the groups from which you got the link from, and we will answer them as soon as possible. Join us again next week for another session on the HICS program, and please do register for the HICS, the 9th edition of HICS scheduled for May 10th to 12th in Hyderabad. See you all soon. Bye-bye.